Hi there, we're going to now talk about pharmacodynamics, and we just talked about pharmacokinetics, how the drug is metabolized. Pharmacodynamics is about how drugs affect the body. There is a little bit of crossover with pharmacokinetics within this slide set, but it's good to understand how they both work together. You can always follow along, so you can basically kill two birds with one stone by following along in the textbook, because the slide sets go right along with the textbook. So, whoops, we don't want to do that. We want to go to, because I already did that. Okay, pharmacodynamics, the way the drugs affect the body. So there's two main ways that they affect the body. There's a primary effect and a secondary. So primary means you take the medicine and it's working the way it's supposed to work. You take an antacid, it's going to decrease the acid, you feel better. A secondary effect is, it could be a desirable secondary effect or an undesirable secondary effect. So I put birth control pill, that's what that stands for, meaning you can take a birth control pill and it helps regulate your periods. But it can also help reduce acne. Or let's say you're taking it just for birth control, but a secondary effect could be your periods are nice and regular. So that's a secondary effect. They could be undesirable effects though. So sometimes maybe you take a birth control pill and your breasts hurt. So that's an undesirable secondary effect that can happen. So that's what that means. So we'll talk about the dose-response relationship, and so what this is how the body responds to changes in the drug concentration at the site of action. So there's potency, so how much of the drug is needed for a response. And so you can have a high potency and a low potency. So example, fentanyl or your morphine has a very high potency of medication, whereas Tylenol with codeine has a low potency, so therefore it's down lower on the list of the schedule. It's just how it's made, and the drug concentration is made of the site of action. Then we have a therapeutic index, which is how it's the area between the toxic dose and the therapeutic index that equals the therapeutic index. So we have a therapeutic dose, meaning, I'll try to explain this in layman terms. The therapeutic dose is the dose that you're supposed to take, but then you can also have a toxic dose and you don't want that. So it's that area between that. And I'll show you the slide here, and you can also find the slide on page 20. And it shows you, so they take 50% of the population, and it helps determine or 50% of the population taking the specific drug to determine what the toxic effect is. So 50% that reach this, that start having adverse reactions perhaps, this is the level of right here, the toxic effect. And then they have the therapeutic effect here, which is the threshold of where the drug starts really working. So this whole thing in between here is the therapeutic index. So there's some drugs that need to be really watched because they are more potent, or they have a high concentration in your body, so they can become toxic really easily. That's when we draw blood to make sure that the levels are good, like digoxin levels, dilantin levels, and we'll talk about peak and troughs in a little bit too. So we have an onset, peak, and duration. So this is exactly, when you take the drug, whether it be by mouth or any other route, it's the time for it to take to reach the minimum effective concentration. And then the peak is the highest, and the duration, how long is it taking for the drug to actually get to that therapeutic state to start to work. So this is just another picture. It's on page 21 if you want to also follow along with that. So it gives you an idea of how you take the drug, and then so many hours later it gets to the peak level. So remember we talked about absorption, how it's absorbing, gets to the peak level, it's distributing into the tissues, and then it's eliminating out in the urine or feces, sweat, that kind of thing that we talked about in the last slide set. So if you see here on the side, it kind of puts it all together, your toxic level and then your minimal effective concentration. Here's your therapeutic range or index that you want the drug at. All right, so how are we going to monitor drugs? Now, some drugs don't need to be monitored, but there's some drugs that need to be monitored that, again, have that high concentration, rapid absorption, have a higher toxicity of drugs. So let's use one example, which you'll hear about, is vancomycin. You'll see that inpatient. It's an antibiotic. It's a potent antibiotic. But it can go over to the toxic level or untherapeutic level very easily. So you need to draw peaks and troughs. There's some protocols now that just do trough levels, but to understand what peak and troughs are, the peak is actually the highest concentration that the drug is at, and the trough is the lowest concentration that the drug is at. So say someone gets vancomycin at 6 o'clock at night, they're going to come right about a half hour before you're going to give the medicine, and you're going to draw a trough level because it should be at the lowest level at that point because you haven't had it in 24 hours. And then you give the medication, and then about an hour or two later, the lab comes and draws blood again, and they check the peak. So they make sure, what you want to make sure is that that drug, this one's a better one, is within this therapeutic index. So let's just say the trough is below here and it's not here, because it really should still be in here when you give it in the 24 hours. But if it's not, they may have to adjust the dose. If it's too toxic, then they may need to decrease the dose of that. So that's I give you an example of peak and trough level. So what's the receptor theory? So all drugs bind to receptors in your body. So we kind of talked about this in the pharmacokinetics. But what it does is bind to receptors, and there's different types of receptors. So I think there's a good figure on page 21, figure 2.8, that helps you to understand the different types of drugs and how they bind to the receptor. So you either want to activate the receptor, you want to produce a response, or you want to inactivate the receptor. So say you are trying to close off a receptor so that part of the body doesn't, let's just say, make too much insulin. So there's reasons where you want to inactivate the receptor. There's some you want to activate the receptor because you want it to work. So if you look at figure 2.8, it shows you how they form bonds with the specific receptor sites, and there's agonists, antagonists, and partial agonists. So if you look at it shows you like there's kind of like a lock and key. So that's the receptor, and then there's the drug with the key. The better the fit, the better the response. So drugs with complete attachment and response are called agonists. So you're going to put the key in, and then it's going to release whatever it needs to release and work. It's going to like promote that specific thing in your body to work better. Drugs that attach but don't elicit a response are called antagonists. You're basically blocking that action of what particular action in that body you don't want to happen. And then drugs that attach partially are just partial agonists. All right. And this is one example of, let's say you're taking two different drugs. You have drug A and drug B. Or let's just say, let me see. Let's go back here. I'm going to use two examples here. All right, you see how drug A here and then drug B, the different keys? Drug A will fit and drug B won't. So that's the difference. So you have an agonist to make it work, an antagonist that's not going to bind to that receptor. The other thing that you want to think about is polypharmacy, which is later on in the slide set, but this is a great example. If you're taking two drugs that interact but yet go through the same pathway, let's just say this drug B has the same looking key, they're going to fight for each other, and so drug B might not be metabolized in your body and work, and then the A may work too much, or may work and then the B won't work at all. So that's just an example of that. So as far as receptor theory continued, there's 4 receptor families. There's cell membrane, there's ligand, ion channels, G protein, and transcription factors. I don't expect you to memorize these, but I want you to understand that there are 4 ways or 4 receptor families, and it just depends on the drug, depending on what cell and where the cell is that it's going to bind to. And that's on page 20 to read that. And we talked about agonists and antagonists. So we either produce the desired response or we block the response. And antagonists are things that are drugs that we take and I'll look for a list of them. But there's antagonists that we actually don't want things to happen in the body. And then agonists, we do want things to happen in the body. So I'm going to give you an example of some drug effects that can happen. So you're taking the drug that's called bethanechol. It's a really old drug, actually. I've really never prescribed it. But it's for to help bladder retention. So, but what it does is this actually goes to specific receptor sites. It's not very selective, put it that way. So the less selective the drug, the more it's basically going to go all over the body, okay? If it's a specific drug or very selective, then it'll probably only go to the place that it's supposed to work. So this drug's an old drug, and it goes to these receptor sites. So not only does it affect the bladder to help people urinate, it also goes to all these other sites that can cause these other responses. So remember I said the secondary effect that could be undesirable? That's what that drug can do. Every drug is different. Here's another example. There's a drug, epinephrine, that you can take for a variety of things, and it goes to multiple receptor sites, whereas the previous one goes to the one receptor site, but it's all over the body. It's not that specific, but this one goes to multiple receptors, alpha 1, beta 1, and beta 2. So epinephrine will cause all these responses. So if someone has an anaphylactic reaction, we want their heart rate to increase. We want your blood pressure to increase, as well as relax the bronchioles. So these are mechanisms of drug actions. How do the drugs work in your body? So it just depends on the drug that you're taking. So stimulation, that would be your epinephrine. The responses that you're going to get in fight or flight. Depression, so morphine, it causes respiratory depression, it decreases your bodily functions. Irritation, that's more like giving an electric shock. It's causing irritation to whatever you're trying to get to respond, like your nerves. Replacement, so let's say you have diabetes type 1, your body's not able to make insulin, so you're going to need insulin to replace the insulin your body's not making. Thyroid drugs, if you've had a thyroidectomy or you're hypothyroid, your body or your thyroid's not able to produce it, so you have to take the drug. Cytotoxic kills cancers, that's chemotherapy. There's certain anti-parasitic medications. Antimicrobial action prevents, inhibits, or kills organisms. And modification of immune status. So that depresses the immune system. These are things people with MS can take, rheumatoid arthritis, like your Humira. It depresses the immune system, but yet it's still working to help. Since, for example, let's use rheumatoid arthritis, it's an autoimmune disease, so your body's attacking itself, so you want to decrease your immune system so it can stop producing inflammation in your body. Unfortunately, you have a decreased immune system, so you have to be careful then of other effects of getting sick. So all drugs have side effects. So there's side effects, adverse reactions, and drug toxicity. So nearly all drugs have secondary side effects. You take a drug, you can get nauseous. You take a drug, you can get diarrhea. I always tell people you may not get side effects. You may be fine, but all drugs have reported side effects. There's adverse reactions. So, I apologize for spelling reactions or adding that extra Q. Let's use, for example, I talked about what side effects were, but adverse reactions are more severe than side effects. So getting hives, having your, let's just say, some drugs can affect your blood count. So it causes that. Things that it's not supposed to do, and so you really need to stop the drug. Shortness of breath. anaphylaxis. Those are all adverse reactions. So when people say that they're allergic to medication, it's important that you ask what happens when you take that medication. If they say, well, I get a headache, that's a side effect. It's not an adverse reaction. But if they say their throat was closing up or they developed hives, that's an adverse reaction. And so we need to make note of that in the chart, because what if somebody really needs a specific drug? Sometimes we have to override and give the medication because we know it's just side effects. Drug toxicity, when the drug level exceeds the therapeutic range, that's when the certain drugs that you're monitoring, digoxin levels, dilantin levels, vancomycin, peak and trough or levels of that. So there's multiple drugs out there to monitor depending on how it is metabolized in your body. There's also drug interactions, and as we know, elderly have polypharmacy, meaning more than one medicine. So that's really important to make sure you look up drug interactions. So to have like Hippocrates app lets you put in all the drugs, and it'll help you determine the interactions. We have Epic, or we have other electronic health records now that kind of help detect that. The pharmacy will also help. So anyways, and then pharmacokinetic interactions, that's changes occurring in absorption, distribution, metabolism, excretion. So remember I showed you that lock and key. There could be certain drugs that are fighting for the same receptor site, or they're just not going to absorb as well, or distribute to the tissues when you're taking multiple drugs at the same time. There could be an additive effect. So you're taking two drugs and it's going to make the one stronger because you're taking the other one. Synergistic effect is much greater than the effects of either drug alone. So that's similar to the additive effects. So think of additive as being both drugs, and then synergistic is going to make one drug more effective. And then antagonistic. Remember I said antagonistic is actually good depending on what drug you're taking for the body response you want. But there's also antagonistic, meaning that if you take two drugs, or three or four, one of the drug can actually block the effect of the other drug, which was that key picture that I showed you. There's also drug interactions, some foods. Do you take on an empty stomach? Do you take with a high-fat meal? Do you take it with food in general, etc.? It can delay the drug response. Drug lab interactions. Drugs can cause misinterpretation of test results. So if you take a drug, a specific medication, sometimes it can cause your lipids to go up, meaning your cholesterol, and it's causing misinterpretation of it. Drug-induced photosensitivity. Let's say you are taking doxycycline because you're traveling over to Africa and you don't want to get malaria, and it's a choice of antibiotic you can take for that. But you have to be careful out in the sun because you can get a reaction. Sometimes, sorry about the beeping. Sometimes you take doxycycline for skin acne, but yet it still can cause skin reactions from the sunlight. Now in the textbook, I did skip, I left the pharmacokinetics to the last, so you probably have to go back if you want to look. But it's really self-explanatory to me because it has to do with your genetic makeup. So depending on what you take, will depend on how you're going to tolerate the drug and it's metabolized. When I tell people, let's just use antidepressants, for example, now they're starting to actually come out with some good blood tests that can determine, according to your genetics, what antidepressant is best for you. It's not 100% effective, but it is helpful. So I'm really glad those are coming out. But traditionally, we say, you know what, I really don't know which of these medications for depression are going to work with you. It's basically trial and error. What has worked for a lot of my patients, I'll choose. If they're elderly, I know which one to choose because of how it's metabolized, etc. So just to give you an idea that now they're doing the pharmacokinetics for the antidepressants, there is a specific blood test you can draw that says, okay, sertraline works, it says it's going to work for you this one can work, but it's saying that to stay away from this drug. So let's try one of these drugs that are going to work. So I'm just going to do some practice questions. I put the answers here because I just want you to work through it with me and make sure you understand it. A patient has liver and kidney disease. He is given a medication with a half-life of 30 hours. The nurse expects the duration of this medication to, do you think it's going to increase, decrease, remain unchanged, so dissipate? So the key things in here are liver and kidney disease. All right, the half-life's 30 hours, so that's pretty long half-life, really long half-life. So what do we expect the duration of this medication to do? So in a normal person without liver or kidney disease, it's still a long half-life. So the half-life and the duration, I mean, is going to probably remain unchanged in a healthy person. But what if someone has liver or kidney disease? It's not going to metabolize like it will in you or I or someone without liver and kidney disease. So that means that it's going to not excrete like it should. So it's going to increase in the body. It's going to accumulate in the body. So those drugs, like geriatrics, you have to be really careful, or people in general with liver and kidney disease. So it increases. When assessing older adults and renal dysfunction, and those with renal dysfunction, you know that creatinine clearance is usually decreased. Okay, because remember that as you get older, our kidneys do not clear out whatever needs to be cleared as well as when we have healthy kidneys or younger. All right, so that creatinine clearance decreases. Body mass, muscle mass has a lot to do with our creatinine clearance. As we get older, our muscle mass decreases. So that gets excreted through the kidneys, and so it decreases. So remember, a creatinine clearance or glomerular filtration rate should be greater than 60. Well, it starts decreasing as age goes on. When you're thinking of a blood creatinine, that will go up. So what you'll see is a creatinine in the blood go up because it's staying in the kidneys, but your creatinine clearance, meaning that it's not able to excrete like it did when you were healthy, actually goes down. I hope that makes sense. If not, ask me. All right, so a patient has significant burns to the skin and has a fluid shift with edema in the fluid overload phase. The nurse would anticipate that this will interfere with which phase of pharmacodynamics. So if you go back to pharmacodynamics, remember absorption, actually it should be pharmacokinetics. I didn't make this question. Which phase of pharmacokinetics? Absorption, distribution, metabolism, or excretion. So let's think about fluid shifting. Absorption is you're going to take it, let's say you take something by mouth, goes to your stomach. So that really wouldn't be associated with fluid at this point and how it's absorbed. But then remember, it goes from that to the vessels and out to the tissues. That's distribution. So it's being distributed out to the tissues. So if there's a fluid shift and there's edema, it's really going to affect how the medication is going to work in that phase. And then which nursing actions would be most appropriate? So when you're taking NCLEX, you're going to get these questions. Nursing actions most appropriate, patient safety, medicine with low therapeutic index. Okay, so you want to monitor patient's urine output, or B, are you going to assess the vital signs hourly, or C, strict isolation, which doesn't make sense, right? Or D, monitoring the serum peak and trough levels. So if you have a high therapeutic index or the low therapeutic index, you want to monitor their serum peak and troughs. Most likely this is a vancomycin IV medication that you're giving. So remember go back and look at low therapeutic index, and remember that therapeutic range, which we saw in this slide here. Oops, yeah, so here's the therapeutic range. There's the therapeutic index, all right? I think that's it. Oh, there's one more. All right, so most drugs are metabolized where? In the liver. There's some that are metabolized in the kidney. Most are in the liver. And there's a very small amount that are in the small intestine. Linzess is a medication that's given for constipation, and that drug's actually just works in the intestines, and it's metabolized in the small intestine. It's really nice drug for constipation because it's good for elderly because it's not it's not being distributed or absorbed anywhere else in the body, just the intestines. So, all right, and that is it.